Rahim. We'll continue on the second part of our lectures about antihypertensive drugs or drugs used for hypertension. We discussed in the previous lectures the first class of drugs used for hypertension, and we said that diuretics is one of the drugs used to control for the hypertension, especially the thiazide. Second class of drugs used for control hypertension called vasodilators. Well, its name or their names mean is dilatations of the vessel which lead to decrease the peripheral resistance and subsequently will decrease the peripheral resistance and control the hypertension. The vasodilators include organic nitrates, and as you know, these drugs are used commonly for control of the anginal pain, whether angina stable or unstable angina, or myocardial infarction to relieve the pain. As we know, the denitrations in the smooth muscle cells release nitric oxide, NO, which is the main physiological vasodilators, are normally produced by endothelial cells. So, the main mechanism is due to the effect of nitrous oxide, which is the main physiological vasodilators. Nitrodilators activate the soluble guanylate cyclase in vascular smooth muscle cells and cause an increase in intracyclic guanosine monophosphate, which is abbreviated by GMP concentration. So this leads to the increase the intracellular cyclic guanosine monophosphate GMP. Now this is considered the second messengers which alter calcium influx in the cells, decrease stored calcium and induce relaxation. So this is the mechanism which lead to the vasodilatations and smooth muscle relaxation. Sometimes ethanol will lead to the decrease the release of nitrous oxide and subsequently will aggravate the vasoconstriction. So this is another mechanism that aggravates the pain, especially the anginal pain due to the ethanol. So the end result is generalized dilatation of venules, which is called, as I mentioned in the previous slide, capacitance vessel, and to lesser extent to arterioles, which is called resistance vessel. And this will cause a fall of blood pressure that is postural at first, and then the larger coronary arteries especially dilate. And this is postural at first, but with time this leads to the dilatations of the large coronary arteries and lead to the relief of the pain of the anginal, especially angina. As you know, this is the nitrate or organic nitrate usually used for the anginal pain. The venous dilatation causes a reduction in venous return and a fall in left ventricular filling pressure with reduced stroke volume, but cardiac output is sustained by the reflex tachycardia induced by the fall in the blood pressure. So when the stroke volume is decreased, this will lead to the decrease the cardiac output. As you know, or as I mentioned in the previous lectures, that the cardiac output is one of the parameters that control the blood pressure. When decrease the cardiac output, this will lead to decrease the blood pressure. What about pharmacokinetics of the nitrate? First uses. Nitrates are chiefly used, as I mentioned, to relieve angina pectoris and sometimes late ventricular failure. And have to have the most important fact that transient relief of the pain due to the spasm of other smooth muscle, example colic, can sometimes be obtained, so that relief of chest pain by nitrate does not prove the diagnosis of angina pectoris. Some of your colleagues consider that when we give nitrate sublingual or orally to the patient with chest pain, when the pain is relieved, consider this is a diagnostic for the angina. This is a wrong fact. Why? Because there is a transient relief of pain due to the spasm of other smooth muscle. Nitrate will cause release or relief of the spasm and the colic and this will lead to the relief of the pain of the spasm origin. This is not give you an indication to this pain is due to the angina. This is very important and have to concentrate on this. Nitrate are contraindicated angina due to anemia. As you know, it might be aggravate the angina because of increased demand to the blood. And the main treatment of the angina due to the anemia is a correction of anemia. What about side effects of nitrate? Collapse, and this is the commonest side effect due to the falling of blood pressure resulting from the overdose. Second side effect, nitrate headache due to the stretching of pain-sensitive tissues around the meningeal arteries. Third side effect is methemoglobinemia can occur with heavy doses. So the side effects, collapse, nitrate, methemoglobinemia. Anyhow, sorry. I will repeat that the main side effects of nitrate, collapse is the commonest side effect, nitrate headache, methemoglobinemia. What about interactions of nitrates? The most common and the dangerous interactions is with phosphodiesterase inhibitor, PDE, such as sildenafil, Viagra, and tadalafil, Cialis, which make potentiation of their vasodilator effect, which is observed, and this might lead to the severe falling of the blood pressure and severe hypotension, and this might lead to the death. Why? Because of the potentiation of their vasodilator effects by this drugs when given concomitant with nitrate, especially the Viagra and Cialis. Somebody asked questions. What about other methylxanthine BD inhibitors such as theophylline? We use theophylline, sometimes theophylline with nitrate, but there is no, we not faced such side effect of the collapse and falling of blood. This is do not cause a similar interaction because they are rather weak inhibitors as PDE5, even at doses effective in asthma. And when give the theophylline in asthma, this not lead to this side effect. Why? Because this drug is rather weak inhibitors of PDE. Why? But the Viagra and Cialis are strong inhibitors of PDE, phosphodiesterase. And we faced a number of pericoital deaths reported in patients taking sildenafil have been attributed to the substantial fall in the blood pressure that occurs when used with nitrate. When used nitrate with sildenafil, Viagra, we have a large rate of what is called pericoital mortality rate. Other type of the nitrate, or glycerin nitrate, trinitrate, is another type of nitrate, and it has the same pharmacokinetics, side effect, and interactions. Second type of the vasodilator is called calcium channel blockers. Calcium channel blockers, as you know, it is, we know in the markets we have Adalat, nifedipine, nimodipine, verapamil, isoptine, etc. These are types or examples of calcium channel blockers. So what about the calcium? Calcium is involved in the initiation of smooth muscle and cardiac cell contraction and in the propagations of the cardiac impulse. This is the role of calcium in the initiation of smooth muscle and cardiac cell contraction. Contraction of these cells required an influx of calcium across the cell membrane, and this occurs through voltage operated ion channels, which is abbreviated by VOCs. And the influx is able to trigger further release of calcium from intracellular stores in the sarcoplasmic reticulum. So the main actions occurs through the voltage operated ion channels. These channels have relatively long opening times and very large fluxes or fluxes. Hence, they are usually referred to as what is called L-type channels. And the rise in intracellular free calcium result in activation of the contractile proteins, which are include myosin and actin, with shortenings of the fibrils and contractions of the smooth muscle. So, the calcium channel blockers, their effects is via decrease the contraction of these smooth muscle contraction, decrease the contraction of these smooth muscle via action or blockage of the voltage operated ion channels. This is an introduction about the mechanism and the physiology of mechanism in the smooth muscle contraction. And there are three types or three classes of the calcium channel blockers. Dihydropyridine is the most numerous. Example is the epilat or adalat, and nifedipines, example of the dihydropyridine. Second type is phenylalkylamine, principally including verapamil. Third type is benzodiazepine, and the example is diltiazem. So, what are the differences between these types? The differences between their clinical effects can be explained in part by their binding to different parts of the L-type calcium channels. So, the differences in the binding of these classes to the L-type calcium is result in the differences between their clinical aspect or their clinical effect. The differences in the clinical effects are due to the differences in their binding capacity to the different parts of L-type calcium channels. The therapeutic benefits of the calcium blockers in the hypertension and angina is due mainly to their action as vasodilator. Pharmacokinetics, calcium channel blockers in general are well absorbed from the calcium channel plaque. All undergo metabolism to less active products, predominantly by cytochrome P450 CYP-A3, as their action is terminated by metabolism. So their action is terminated by metabolism, undergo metabolism to less products by cytochrome P450, and are generally well absorbed. Indication: the main indication is hypertension, example amenodipine, ezrabidine, nicardipine, nifedipine, verapamil. And then the first indication of the calcium channel blockers is hypertension. Second, angina, example amlodipine and diltiazem. Cardiac arrhythmia, example verapamil. Raynaud's phenomena, example nifedipine. Other indication: prevention of ischemic neurological damage following subarachnoid hemorrhage. Side effect: headache, flushing, dizziness, palpitations, and hypotension. Ankle edema may also develop, and this is due to the rise in intracapillary pressure. Thus, edema is not a sign of sodium retention and is not relieved by diuretic but disappear after lying flat. Example of have to give the drugs over the night. So, headache, flushing, palpitation, hypotension, ankle edema. Bradycardia and arrhythmia may occur especially with the non-dihydropyridine. GIT effect, non-specific, constipations, nausea, vomiting, palpitation, and lethargy. There has been some concern that shorter acting calcium channel blocker, example verapamil or example nifedipine adalat, may adversely affect the risk of myocardial infarction and cardiac death. Interaction: decreased effect with enzyme-induced, example rifampicin. Calcium channel blockers decrease the plasma clearance of several drugs. Verapamil increase the plasma concentration of digoxin. Beta blockers may exacerbate AV arterioventricular block and cardiac failure. Grapefruit juice raise the plasma concentration of dihydropyridine. Individual calcium channel blocker, we have nifedipine, we have which the main side effect is the gum hypertrophy, amlodipine, verapamine, deltiazine and nimodipine. Thank you very much.